Thank you very much. I mean, it is indeed an honor to be here. And thank you, Dr. Khalil, for very kind introduction. And it is really a pleasure to be here at Texas Art Institute, and I'll use it as a tribute both to my parents and to Dr. Cooley, Dr. Rule, and Dr. V.S. Mathur. I had brought my dad here to Texas Art Institute from India back in 1988 when he had a seven-vessel bypass with two arterial grafts in 1988, came with ejection fraction of 23%, pump run of 48 minutes. And it was a unique case where Dr. Rule and Dr. Cooley washed together to do it. I don't know why. They wanted to impress the All India Institute or whatever it was. But he left Houston 6 weeks later with an ejection fraction of 65%, lived 14 years thereafter, not needing a single tablet of nitroglycerin, and dying of bladder cancer. So, and these are the pictures from the OR from that time. And this is the way the Texas Art Institute looked in 1988. And just to show you that I had started doing the ammonia scans back in 1980s in India, which I carried out, and Stephanie would remember, with Ron and Henry Coverts and Hiro Yasuda, that I did at Mass General also when we started doing the ammonia PET scans there as well. So I'll be discussing three important things today. What is the role of CT in geography? What is whether our focus should be on plaque, patient, or population? And is it really possible that we would be able to eliminate coronary disease in our lifetime? So I have no conflicts of interest here. So let me start with a simple statement that we always know, and it is pretty well established, that coronary artery disease is bad because it causes major adverse events. But the algorithm has been somewhat simple. We have had dogmas which we have carried for almost 50 years now, that there is progressive atheroma that leads to significant stenosis. When there is stenosis, it reduces flow, so there is ischemia. And when there is ischemia, it causes events. Now, if the algorithm is so simple, so should be the management. And that is that we should just be able to find stenosis because it causes ischemia. We should find ischemia because it causes events. We should treat stenosis because that will reduce ischemia. And then we hope that will be by fixing the stenosis and reducing ischemia, we will automatically decrease myocardial infarction and deaths. But is it true? And have we been able to do that? All that dogma had started from the major surgical trials of 1980s and early 1990s, where they had randomized the patients to surgical revascularization of the coronary arteries, which were greater than 70% occlusive, and compared them to the optimal medical therapy of those times when we did not have beta blockers, statins, ACE inhibitors, or aspirin had just started. And if you see that on the long term, there was a significant improvement in survival with the surgical therapy. Not only that, the angina was significantly improved in the revascularized cases, and their exercise tolerance improved substantially. Now, the 70% came from the outstanding studies of Lance Gould and his colleagues. And as you can see here, that the CFR would break at about 70%. And that is the gold standard that we have seen. But at that time, those animals had normal coronary arteries. There was no atherosclerosis. And you had occluded a single coronary artery by a ligature and decreased it to the 70% or caused the 70% stenosis so as to demonstrate the CFR. And then at that time, when we did not have the medical therapy, was the pathology the same as we see today? And the fact remains that in the absence of statins, at that time, as has been shown by Michael Davies and some of the other pathologists, that the lesions were pretty different. These were the lesions with the large amount of necrotic cores, and with the thin fibrous caps, the so-called vulnerable plaques. And even if you see a stable plaque where there is a very thick fibrous cap, you still would see that there's a large necrotic core here, something what is not as obvious in these days when we have started to treat our patients with the lipid-lowering therapy. So obviously, it required a new investigation where the modern optimal medical therapy was compared with the revascularization. And in a very courageous attempt, Borden and colleagues, when they came with the Courage trial, you saw the effect on the primary outcome, and that the optimal medical therapy and revascularization with optimal medical therapy, there was essentially no difference in the outcome at 5 years. And that was the time that we saw a significant drop in the number of the PCIs across the world, not only in the United States, but across the world. But at the same time, the importance of uh, the functional importance of the lesions was being demonstrated by the FAME group of studies. And as you saw, that in a very natural evolution of the FAME studies, that the subjects with abnormal FFR were subjected to optimal medical therapy versus the PCI and optimal medical therapy. And it was demonstrated that PCI did much better as compared to the optimal medical therapy. The trial was stopped at 7 months because they had met the primary endpoint, but was significantly criticized because all the events were the revascularization events and not the hard events that we would be looking for. However, when you go and look at the 5-year outcome in these cases, you will still see that the difference between the PCI and the medical therapy was maintained. However, it was essentially the same, which was by the need for revascularization, and there was no difference in the death or in myocardial infarction, even though the number of the myocardial infarction, spontaneous infarction, was greater as compared to PCI, but it was essentially not the statistically significant outcome. Now, the question is, how do you reconcile these results? And if you really look at the outcome in the Courage trial also, and that was shown by Dr. Borden's editorial, which he had written on the FAME2 trial, you saw that the need for the urgent revascularization was essentially the same as we saw in the FAME2 study, suggesting thereby that it does not increase the number, it doesn't increase the mortality. And as far as the revascularization is concerned, you at least don't have a mortality penalty in these cases if you subject these cases to optimal medical therapy. However, we thought that we will get better answers from the ischemia study, because that was the study which was enrolling patients. They were doing CT angiography ahead of time. And we were able to exclude those cases which were likely to sway the results in the favor of the optimal medical therapy when we had extensive disease, left medical treatment, left main disease, or the normal coronary vessels. And essentially those cases where the revascularization needed to be compared to the optimal medical therapy were the ones which were included in the ischemia group of studies. However, the results were essentially the same. As you would see that at the end of 5 years, there was no difference in the optimal medical therapy arm as compared to the invasive arm. However, the results of the myocardial infarction, which was demonstrated in the sub-study, which was published in Circulation by Dr. David Marin and Judy Hockman, you can see that there was a significant difference in the number of the subjects who had spontaneous myocardial infarction, again, showing the same results as the Courage and FAME2 trial. The spontaneous myocardial infarction rate in the conservative arm was approximately 6% compared to the invasive arm, which was about 3%, with the absolute risk reduction of 3% or relative risk reduction of more than 50%. So the question that arises is that did ischemia demonstrate failure of revascularization to reduce myocardial infarction, or failure of ischemia testing to guide revascularization? So the onus is on us to find out who will live without events and who will die of preventable events and when. So when we were looking at the FAME2 study, if you remember from the 5-year survival data of the FAME2 study, although there was no difference in the number of patients who died or the patients who had myocardial infarction, the only difference was at revascularization, which was maintained up to 5 years. 50% of people at the end of that study did not die, got revascularization, and had a similar relief from angina as that was in the revascularized arm, suggesting thereby that these 50% of the subjects could have been easily avoided from getting the revascularization, or the optimal medical therapy would have been as effective as the revascularization was. And with that end in view, Samedi et al., they picked up in a very elegant study design, they picked up those subjects who were treated with the optimal medical therapy, and they started to look at their plaques. So they reconstructed their 3D invasive coronary angiograms and started to look at the wall shear stress. Now, the proximal to the plaque, the wall shear stress suggests the difference in the plaque constitution. And they demonstrated that whenever there was a significantly higher plaque shear stress, these were the subjects who had events in these optimally medically treated subjects as compared to those who had normal wall shear stress. And when they compared, they found that the combination of the FFR and wall shear stress in these subjects with less than 0.8 FFR, they did much worse as compared to those who had abnormal FFR but had normal wall shear stress, suggesting the importance of the plaque constitution or plaque composition. So, if we try and put it all together, what we used to think, what we now think, and what we should actually be thinking. So we started to take the patients for revascularization, all those who had 70% or greater occlusion of their coronary artery. And that was all based on the coronary artery surgery study group and other mega surgical trials of revascularization that suggested the relevance of anatomic stenosis. However, with the FAME group of studies, as we can see here, that this trial had demonstrated the safety of deferral of the FFR negative lesion, regardless of the degree of luminal stenosis, and it took away approximately 33% of cases which otherwise would have been subjected to revascularization. However, with the FAME2 study, as we discussed, that 50% of the FFR positive lesions on optimal medical therapy remain event-free with no difference in the rate of death and myocardial infarction, revascularization, or angina, we should be able to take another bite away of 33% of subjects, leaving alone only 33% of the people who would actually require revascularization, giving us the importance of the plaque composition in those cases. Now, the plaque composition, as we know, the subjects who have acute myocardial infarction or sudden death have very distinct plaque characteristics. As you will see here, that in this particular case, there is a huge necrotic core in the lower half of the plaque. You can see the necrotic core with a lot of cholesterol crystals in this. And then this is the fibrous cap, which thins out at this place. And whenever the fibrous cap thickness is less than 55 micron, it suggests that the plaque is vulnerable. And at the thinnest of the site, the plaque gives way, and the thrombus could form as the necrotic core is exposed to the blood. And necrotic core, as we know, is significantly rich in the tissue factors and other thrombotic or prothrombogenic factors. And there is a thrombus which forms, occludes the lumen, and results in an acute event. And if we have such plaque characteristics, but if the plaque cap is still intact, we call these plaques as the plaques which are at high risk of rupture, or the plaques which are vulnerable to rupture. And as you can see here, that these are the 3 plaques which are vulnerable to rupture with a significantly large necrotic core. These plaques are high volume or large plaques. They have large necrotic cores. They have very thin fibrous cap. These caps are normally significantly inflamed, as you can see here with the blue color stains of the inflammatory cells in this particular case. So if you look at these three cases, the characteristics are same. They all have large necrotic cores. They all have thin fibrous caps. And the difference is that in this particular case, there is no occlusion of the lumen. The lumen is normal. In this case, the lumen is modestly occluded, and in this case, the lumen is significantly occluded. So why is it that these cases with no luminal occlusion still are amenable to plaque rupture? And we know that this can be explained by the Glagoff's phenomenon, that initially when the lipids start to deposit, there is an expansion, which is an outward expansion. And that is something what we all call as the positive remodeling or expansive remodeling, until the necrotic core or plaque volume has reached at least 40 to 60% of the total vascular area. And it is only after that that the plaque starts to impinge on the lumen, and it comes with vengeance. There is a significantly rapid progression of these plaques, and the progression of the plaque is now considered to be one of the most important characteristics of the plaques which are vulnerable to rupture, and it results in events. So, working at that time with the CT angiography, and this was 2003 when I was in the University of California in Irvine, that I had received my first gift of the CT scanner from Toshiba. And that was the first 64 slicer which had come to the country, which was gifted to us. And we got a significantly large amount of money from them so as to identify or describe the plaque vulnerability and tissue characterization. At that time, people had started to laugh at us when we started telling them that we will be able to identify the vessel wall. And as you can see here, that in our first study, we had demonstrated the correlation of the vessel wall on CT angiography compared to the intravascular ultrasound. And then in our second study, we demonstrated that in the subjects with the acute coronary syndrome, if you would do the CT angiography, you'll be able to identify the vascular characteristics. As you would see here, quite like pathology, there is a significant positive remodeling here, as you can see here, as well as on the other side with the yellow arrows here, that there's a significant positive remodeling. And the second important feature that we found was the presence of low attenuation plaque, or whenever the plaque density was less than 30 Hounsfield units. We called these plaques as two-feature positive plaques because we wanted to call it a soft plaque or high-risk plaques, but the reviewers and the editors were not happy with that kind of a designation. And they said that since you have not done the prospective study, you would not be able to call them as soft plaques or high-risk plaques. And they wanted to give us a very non-specific name. So I called it a two-feature positive plaque, positive remodeling and the low attenuation plaque, and the paper got accepted. And now it is that it has become a lingo now. Everybody calls them as two-feature positive plaque. And if you find a third one, you call it three-feature positive or four-feature positive plaques. So, however, this was something which is quite correlated with the acute coronary syndromes. And when you look at those plaques which are two-feature negative plaques, they were the plaques which associated with the stable plaques on the intravascular ultrasound. And here you will see that there is a critical lesion, but there's no positive remodeling, and there is no low attenuation plaque in this particular case. Now, when we looked at 1,000 subjects and followed them for at least 2 years, you would find that those which are two-feature positive plaques, they had 22.5% likelihood of having an event over the next 2 years, as compared to less than 0.5% likelihood in the two-feature negative plaques, giving us the hazard ratio of 45:1. And the more the remodeling index, the greater the plaque volume, the greater the necrotic core volume, or the maximum necrotic core area or maximum LAP, or the low attenuation plaque area, to plaque area that related with the greater likelihood of having an acute event, and earlier occurred the event if there was a greater plaque volume and greater necrotic core volume. And at that point, we thought that we have found an answer, and we would be able to identify all those people who are likely to have these events. And we started going around and talking about the vulnerable plaque. Our next study was a 10-year follow-up and of 3,000 subjects. And we demonstrated that, yes, the high-risk plaques indeed were high-risk plaques, and there was 10-fold higher likelihood of having an event as compared to the plaques which were non-high-risk plaques. However, non-high-risk plaques were not as benign as they were at 2 years of follow-up. At 2 years of follow-up, almost there is no event with the non-high-risk plaques. But then as the time goes by, quite a few high-risk plaques start to progress to become the high-risk plaques, and they would result an event, suggesting thereby that the only way we should be able to monitor is by looking at the CT angiograms over and over. Now, the bigger problem here is that at any given time, 90% of the plaques are non-high-risk plaques. So even if there is 10-fold higher likelihood of having an event with the high-risk plaque, at the end of 10 years, the same number of high-risk plaques would have an event as would be the non-high-risk plaque, throwing everything into jeopardy. So if you look at the plaque progression, 500 of our 3,000 subjects had the serial CT angiograms done at an interval of about 1 year. And as you can see here, that over and above this 10-fold risk of the high-risk plaque, there was 35-fold higher likelihood of having an event if plaque demonstrated a plaque progression over the next 1 year, suggesting thereby that if the plaque has the high-risk plaque features, and if it progresses over the next 1 year, there is a very high likelihood of having an event as compared to high-risk plaques if there was no plaque progression. And it essentially falls into a safe category that if the plaque does not expand over the next 1 year, suggesting thereby that there is non-progression, this plaque is not going anywhere. On the other hand, if there is a non-high-risk plaque but shows plaque progression over the next 1 year, there obviously is a significant increase in the likelihood of having an event. And as I earlier said, that the number of events that occur because of the non-high-risk plaques versus those which occur from the high-risk plaque happens to be the same at the end of 10 years, suggesting thereby that we need to do something different than just keep doing the CT angiograms in these cases. Now, when we are talking about the plaque progression, there is another major thing that we have seen. And that is that when we were comparing the FFRs, these are the invasive FFRs, with the plaque characterization, we found that FFR correlates to two things. One is obviously, as I would expect, to the quantitative coronary angiography. There is a significant relationship here. And the second significant relationship comes with the low attenuation plaque volume, regardless of what the stenosis of the lumen is. Now, how can it be that FFR can be abnormal when you have no luminal stenosis or minimal luminal stenosis, but there is a large necrotic core sitting outside the lumen? And the fact remains that it can also be explained by the Glagovian hypothesis here, that once the plaque is expanding outwards, it is expanding the external elastic lamina to the maximum. And when you give the adenosine or nitroglycerin, it is able to expand or dilate the epicardial coronary vessels above and below the plaque to the maximum, while it creates a bottleneck because it is not able to expand further. And because of that, the FFR becomes abnormal. And the number of events in these cases are significantly higher. And that is what we just presented in our last study of the series on the CT angiograms, where we were able to piece it all together. And we looked at the FFRs and whether it is the abnormal FFR or normal FFR, and compared them to the high-risk plaques and absence of high-risk plaque. The maximum likelihood of having an event was when you have an abnormal FFR and the high-risk plaque. And there is no doubt that the subjects with revascularization in this group do much better than those who are treated with the optimal medical therapy. On the other hand, if there is a high-risk plaque, but FFR is normal, in those cases, again, revascularization did better than no revascularization, but that was statistically not significant. On the other hand, if the FFR was abnormal, something what we practice today, but there was no high-risk plaque, there was essentially no difference in revascularization and no revascularization, suggesting thereby that this is the group which represents the true courage group or true ischemia group. And could this population be safely deferred from the FAME2 definition? And finally, those where the FFR was normal and there was no high-risk plaque, obviously there was no advantage of doing revascularization in these cases, and the results to some extent also support what we saw in the Prospect 2 trial, that if we are able to find those which are eminently or imminently likely to get into an event, we basically should be able to use the revascularization to seal these plaques. On the other hand, those subjects where the FFR is still normal, high-risk plaques are there, or those cases where the FFR is even abnormal and there are some likelihood of having the necrotic course, such cases should be able to respond to the anti-lipid or lipid-lowering therapy significantly. One of the very good examples here, which we are presenting as the imaging cases in JACC imaging, we saw a subject. He's a CEO of a company whose dad died at the age of 51, and he has been really scared and takes care of himself. And at the age of 70, he still did not have much of problems other than the fact that he's recently started to have significant chest pain on exertion. We put him on treadmill test and we find that that was true. And then we did the CT angiogram. And as you can see here, that the CT angiogram, there was a significant drop of the FFR at the mid-LAD region. Now, if you look at the stenosis, there were less than 25% stenosis at this area, but he had a huge necrotic core and significant positive remodeling. Now, there are some softwares which have even started to tell us that they will be able to give us the likelihood of the fibrous cap thickness, which I still do not believe, but it is being kind of claimed that we are able to measure the fibrous cap thickness as well by the use of the AI tools. Now, when the patient was maximized on statins with 80 milligrams of rosuvastatin, and we increased and we added the ezetimibe, his LDL dropped to 37 milligram percent. You will see that within 6 months, the necrotic core has shrunken. And as you would see here, that the positive remodeling has disappeared. And if you look at the FFR has normalized in this particular subject. We have demonstrated the same in the invasive lab as well, that if you look at the intravascular ultrasound or the infrared here, that with the decrease in the lipid content of the plaque, there is an improvement in the FFR over a period of time. And in the recent study by Dr. Steve Nichols and Steve Nitzan, and then also by something what we presented this past year with the use of the PCSK9 inhibitors on top of the maximum statin therapy, that we were able to further reduce the likelihood of the lipid deposition in the plaques over a period of 3 months. So now, if we look at the role of lipid lowering, you'll see that in the Interheart study, which I believe is one of the best studies of our time, which was presented by Salim Yusuf in 27,000 subjects in 52 countries, which is a case control design in these cases. If you look at the ApoB to ApoA1 ratios and you look at the deciles, you'll see that there is one-to-one correlation with the odds ratio of having heart attacks in these subjects. Now, this remains same whichever country or continent we go to. Now, as you would see here, whether we are in Europe or in North America or in South America or China or South Asia, wherever we are, we see that the likelihood of the hypercholesterolemia causing the event remains the same. Now, not only that, if we go as far back as 4,000 years, we would find almost the similar results. And these are some of our very fascinating studies where we started to look at the atherosclerosis in the human remains from 3,000 years or 4,000 years ago. And we started to do the CT angiograms. This was the Horus group. We call ourselves Horus group. We are a group of cardiologists, radiologists, anthropologists, archaeologists, pathologists, radiologists. So a lot of us which have gotten together and have gone from continents to continents, and we have now imaged approximately 300 plus mummies from various areas. We started from Egypt, and we were hoping that those people lived much better lives as compared to us. There were no McDonald's, no Kentucky's Fried Chicken, and they lived much better in those days. And they should not have had the coronary artery disease. So here is one of the sarcophagus from the Museum of Antiquity in Cairo that we take it. And then from here comes the mummy. And we image the mummy. And as you can see, that some of the mummies from Egypt still have the hearts intact, specifically the earlier ones, 3,500 years ago, and where they were able to use keep the solid organs also. And it was possibly because the embalming fluid and the embalming ointments were significantly superior at that time as compared to what we have seen in the later part of the Egyptian civilization. So here you would see that there is a significant calcification of the right coronary artery, the left anterior descending coronary artery, and if you will see the bifurcation of the aortoiliac bifurcation, there is a significant calcification. So when we found all this unexpected finding, we felt that there was something wrong, and the risk factors probably are not related. We are just doomed. We are supposed to have atherosclerosis regardless. And if these guys had it at the 55 years of age, we are supposed to have the atherosclerosis. However, when in our discussions and then reading about it and talking to all those scientists from or the archaeologists and historians of Egypt, specifically Dr. Zahi Hawass, who was their Minister of Antiquity and who was the author on the paper with us as well. And so he just discussed about it, that these were the elites of Egypt who were carried in the palanquins. And these were the people who had started cultivation, and the human race had evolved from being the hunter-gatherers to now a civilized society. They had started doing the animal husbandry. They had started cultivating. They had access to the food 3 times a day, as compared to those who used to be like intermittent fasting or maybe eating 2 times a week or 3 times a week or whatever else it was. And then they were quite used to festivities in the palace, and the festivities were, they will use the delicacies. And what were the delicacies? The bird eggs of different sizes. So what is it that we do today and these people did not do at that point in time? And they demonstrated approximately 34% likelihood of having the vascular calcification in their human remains, which is as good or probably worse than what we see even today. So we thought we were at a wrong place, and we needed to go to a place where we had an access to the mummies of the commoners. We ended up in Peru. In Peru, in the foothills of the Andes mountain series, these are the farmers or manual laborers. 50% of them are vegetarians, 50% of them consume alpaca. And alpaca, as we all know, is a very lean meat, or they use some of the sea mammals. And so essentially, a very good diet. They go up and down the mountains. They are completely they indulge in the heavy exercise. So we thought that we should be able to do much better with this population. And so what happens in that part of the world is that once the patient or the person dies, they would put him back into the knee elbow position, as you would see here, that you have to return to the afterward in the same way as you came to this world. And then they would wrap them in the rags and bury them. There is so much of a salt in the soil that quite a lot of these remains, they basically are mummified naturally, unlike the unnatural mummification of Egypt. So when we looked at these, approximately 24% of them also had evidence of vascular calcification. And we were quite surprised now this is a much better population. This is the way we want people to live. And even then, if these people are going to have atherosclerosis, there is something wrong about our hypothesis of relating the risk factors with atherosclerosis. However, when we visited those areas from where these mummies come, we looked at they lived in these shallow huts or hutments there, and they used to cook inside. And how we figured that out was when we looked at their autopsies, and we found that they had the black lungs also in those subjects who had evidence of atherosclerosis. And it was more so in the women and in the younger age women, where we normally would not like to see atherosclerosis so extensively. Not only that, when we ended up in Utah, Arizona, New Mexico, Colorado, in those areas from where the Anasazi Pueblans, approximately 300 years old mummies, come from, we found a significant amount of atherosclerosis in these subjects also. And as you would see here, that they lived in the cliff holes or in the pit holes, as you can see here. And again, the most important part was that they will light fire inside their homes, and you would see that there is only one exit here for the smoke to leave. And they also had a significant likelihood of having the vascular calcification to the tune of up to about 60% of their remains. Something very similar we found in Aleutian Islands and the Alaskan mummies as well. The same thing, subterranean houses, they will light fire, they will all live there, specifically because of the cold weather, even though they were the hunter-gatherers, and they would be consuming food whenever they are able to get the food. So maybe they will be eating 2 to 3 times. But even in these Unagan hunter-gatherers, we found, because of the same reason, that they had significant calcification of their coronary vasculature as well as of the aortic arch. So something similar in the Greenland, in the Greenland Inuits. Again, the same thing, that they would have the fire inside their igloos. And this is something which can be well correlated. And these are the excellent pictures that I've gotten from Annie Griffiths, who is the senior photographer with the National Geographic. And she has gone from country to country, and she has looked at what happens within the kitchens in the low and middle income countries, and how the women and children are exposed to extensive indoor smoke, or so-called indoor pollution. And now our word in data demonstrates a significant importance of indoor pollution in the causation of atherosclerosis and in low and middle income countries. Not only that, the Utsi, the Iceman, 5,000 years ago, are the CT images from them demonstrate that he also had calcification of the iliac vessels as well as that of the carotids. But his stomach content analysis demonstrated the consumption of goat, or the mountain goat, in Utsi as well. So we ended up, and that will be the last part of that talk, we ended up looking at one of the tribal populations from Bolivia. These are the Chimane population from Bolivia, which is from their Amazonian woods. And these are the people who are expected to live very long. And so most of the people live into their 80s to 100. If they don't die early during their neonatal and the early period, these people normally live very well late into full age. So this is, as you would see, that this is the tribe which lives along the river Manuki, which is a tributary of Amazon. And here we are flying from La Paz into Santa Maria near the Chimane village, and then we went to the Chimane village on the kayaks. And here is these are the houses along the river. And if you go deeper inside, the population is even healthier. And so these are the subjects who will hunt pigs, jaguars, and monkeys. And they walk whole day. They walk approximately 15 to 17,000 steps a day, or they hunt for the piranha fish. And then they have some access to wild maniocs, plantains, some mangoes and papayas. And they prepare the food, live in the open huts. There is no pollution, and they eat only once a day. So in the night, they would be eating. So essentially the intermittent fasting here. And as you can see, that this is one of the most favorite couples. This is a 99 years old woman with her 85 years old husband. Here, they had come for their cataract surgery at that time when we were seeing them. So these are the happy folks. They're all living into their 90s and 100s. And as you can see here, that their LDLs have been between 30 to 70. It has never exceeded 70. Their blood pressure systolic has been 115 or below. Sugar always less than 80. Their BMIs have never exceeded 24. They walk 17,000 steps a day. They live in the open huts. There is no air pollution. They don't smoke. They have no coronary artery calcification. And this is the healthiest hearts that you can see anywhere in the world. This is the data that comes from the MESA trial, and you can see any and every kind of the culture from across the world, and then you compare them with the Chimane population, where the likelihood of having 100 coronary artery calcium was less than 8% over the age of 80. So when you look at their 2004, 2007, and 2011 surveys, so these people, we have now 700 coronary artery calcium scans there, and approximately 3,500 carotid ultrasounds from these subjects. We found that from 2004 to 2007, their LDL cholesterol was between 30 to 70. However, in 2011, it went from 70 to 110. And we didn't know what was going on. And the explanation provided to us was that they found motors to put into their kayaks. And now that they used to go to the city, and they would basically take 3 days that they would pedal to the city. And now they are able to reach the city within 2.5 hours. So they proposed that it could be the lack of exercise. So when I said, you know what, how many times do they go to the city? So it comes up that, oh, we go once a month. So that exercise is not going to make a difference. What do you buy in the city? And they buy sacks and sacks of sugar. And why do they like sugar? Because sugar tastes good. Men like it. Women like it because now they put it into their stew. The stew has turned into a syrup. But that does not go bad for 7 days, and they have to cook once in a week. So basically, it's good for both. And that probably was the reason. And now we have demonstrated a clear link between the sugar consumption and the PCSK9 development and the removal of the LDL receptors from the hepatocyte surface. So if it is all about cholesterol, if you look at this data from Dr. O'Wolf's group, that if you put all the secondary prevention trials together and try to extrapolate them, you will have to bring your LDL down to 30 to decrease the events to zero. For primary prevention, you would need to have about 50 milligram percent of the LDL so as to not have the coronary events. And when we look at all the animals of the world, all the animals of the world have total cholesterol of 100 or less. There is just one animal which is proud of 200 milligram cholesterol, and that is human. Not only that, recently presented electrophoretic data, if you will see that the HDL is always more than LDL across the animal kingdom. There are only two animals where LDL is greater than HDL. It is either human or the pigs. The pigs, however, are more intelligent because their LDL is still 35. They are born with 35, it remains 35. We are the only ones where the LDL is greater than HDL because we increase our LDL to what we increase it to. Look at what we are born with. We are born with 25 to 30 milligram percent of LDL. Within about 3 years' time, it goes to 150 milligram percent. What do we feed to our children? And essentially, as we have shown, and that was the question, I do not know whether Dr. Khalil remembers it or not. My daughter, when she was 3 months pregnant and she was in the final year of her cardiology fellowship at Cornell, and she came home and she asked me, Dad, what am I going to feed your grandson when I go back to work? You give all these lectures everywhere, but would you be able to tell me what am I going to feed him? So believe me, I put everything on a back burner in my lab. We started working on it as to what exactly correlates with an increase in the LDL when the child becomes 1 to 3 years of age. And working with Tom Lucier and Joe Hill, we described that it is the it is the sugar, hyperinsulinemia, PI3 kinase pathways, AKT, mTOR, they increase the PCSK9 development, which binds to the LDL receptors, and LDL receptors are gone. And what kind of formula we get in our country is basically all full of corn syrup, corn solid, stable sugar, and whatnot. So essentially what we are feeding to our children, and then after that, Cocoa Puff, Captain Crunch, Cinnamon Toast Crunch, and whatnot. So when we calculated the amount of sugar that we feed into our children in the first 3 years of life is almost unimaginable. And that is the reason that I started to import the formula for my grandson from, and the poor kid has not tasted anything which has sugar. He is 4 years old now. So I do not know whether that experiment will succeed or not, but I don't think I have harmed him. So European Society of Cardiology, as you know, at least in the high-risk cases, has already started to suggest that our LDL level should be less than 40. We chicken out in our country. Our guidelines will take much longer to come to that level. And I would like to end with this brilliant opinion piece by Dr. Braunwald, as you had seen, that he had suggested that if we are able to give one inclisiran once a year, starting at the age of 35, we'll be able to add 30 years more to the human life without having a heart attack. So, can we eliminate coronary artery disease? It's for you to decide. Thank you.